Good afternoon, friends. It's Friday afternoon, 3 o'clock, and we are back from the Scientific Society of AVMC, a constituent college of Vinayaka Missions Research Foundation, with our webinar series, Forefront of Future Frontiers. This webinar series we had started with the intention of sharing what are the novel diagnostics, therapeutics, cutting-edge technology, and also the latest research findings, how we can actually bring it into mainstream practice. That was the intent with which this webinar series started. And we are quite happy that we have traversed quite some distance and time in this with a lot of very interesting and educative experiences along the way. So we are now in series 11 and today is episode number 63. The theme of this particular series is on how we can translate evidence into practice. What can we do about it? And today we have another one interesting talk on actually looking at evidence through looking glass, like how Alice did, and how this is going to change practice. So that's the theme for today. And we have with us Dr. Abirami Krishnan, who's whom I can call as my best friend. And she's a nephrologist from Salem, Kauvery hospitals, and she will be talking to us. So before we proceed, I'd request our Dean, Dr. P.F. Kotur, to give a welcome address. Over to you, Dr. Kotur.
Yeah, thank you, Dr. Mahalakshmi. I'm indeed honored this afternoon to welcome Dr. Abirami, who will be the speaker today to share the dais on the 63rd episode of this Triple F of the Triple F webinar series, the pride of AVMC, which have started almost 20 months back and going uninterruptedly, heading towards a century. This is what I always say. I'm a very optimistic person. And on this platform, many reputed national, international scholars, academicians, researchers, teachers have shared their expertise, they shared their knowledge. And if I recollect correctly, even this evidence-based medicine has shared, this is the third time I think this issue related to practice of evidential practice that is being shared here. And we are very proud to say that, this issue related to evidence-based medicine was shared by none other than the pioneer or the father of evidence-based medicine, Dr. Gordon Guyot. He shared not long back to commemorate the Golden Jubilee episode of this Triple F webinar. And a little bit inclined towards EBM, and certainly I don't miss this opportunity to share a few thoughts on this occasion. See, there has been, we all know that EBM was started somewhere in 1990, somewhere in 1988 to 92, 93. It was put out in the born, new EBM concept was born in the McMaster University, Canada. Now, if you just look back, when the whole idea, the new paradigm was put forth, they started becoming very much popular. At the same time, whenever new thing comes, lot many hassles, barriers, opposition, all kind of things also come. And initial was the very senior faculty like us, they all felt threatened that their position will be shaken by the CBM, and that was one phase. Then, of course, that era, this IT, though was coming in, it was not as exploded like it now. And the other facilitations for the practice of BBM, lack of expertise, lack of facilities was another hassle, and we tried to overcome that. Then there are peculiar problem to countries wherein alternative systems are existing. For example, China and India, they constitute about almost more than half of the population. In these two big countries, the alternative systems of medicines also play a very important role, rather a dominant role, wherein to practice those systems of medicine, there is no evidence. So that will complicate the picture. Our India, for example, majority of the population is located in the rural area, and all kinds of practitioners, other than the allopathic practitioners, are the ones who are there and who are taking care of the national health, and people have got more faith in them than us. So that is the another barrier we can say. And then for the past almost 2 years now, COVID came and posed new challenges for the evidential practice. So it became all messed up, all kinds of evidences coming, complicating, and all the physicians who were ardent practitioners of EBM were their thought processes were shaken, because what is true today in this 1 hour will not be true in the next hour. That was a real situation in a little exaggerated way. So somebody, and all kinds, including reputed journals, reputed agencies, international agencies, they erred. They made mistake, putting something, retreating back, including the watchdog of the health across the globe, or W Health, our World Health Organization as well, has some problems. So we all are aware on that. And along with this, some in the past or more than a decade, this personalized medicine has come, which has put a very definite challenge. See, evidence-based medicine is compared, you can say, on a group of the patients, cohort of the patients on whom you generate evidence, and that is the highest evidence, RCTs, meta-analysis, or systemic reviews, we call that. And the exact opposite to that is the other end, personalized medicine. So these are some of the challenges EBM ever since its birth has been seen. We're all quite aware of that, but certainly it is not shaken. It is going stronger only. It's by that, and each one has got a different role. What I'm talking is personalized medicine as well as the EBM. So these are some of the thoughts that come to my mind randomly here, and certainly even I am also eager for Dr. Abirami will be addressing this issue about this evidence-based medicine or evidential practice of medicine. And so I think that's okay. And I take this opportunity of welcoming her on behalf of AVMC, on behalf of our Vinayaka Mission Research Foundation University, on behalf of our management, Honorable Chancellor, Madam Chancellor, and other board of management members. Once again, I welcome you all. Over to you, Dr. Mahalakshmi, to introduce our speakers.
Thank you very much, sir. Yeah. So Dr. Abirami is the consultant nephrologist and deputy medical administrator, Kauvery Hospital, Salem. She did MBBS with me in Kilpak Medical College, and then went on to do MD General Medicine from Safdarjung Hospital, Delhi. Then she joined AIMS for her DM Nephrology, and she moved on to Tirupati, Venkateshwara Hospital, where she worked for some time before she proceeded to Canada for further studies. She did fellowship in nephrology in Canada and completed her MRCP on the way back to India. So that is what her journey was with regard to that. And after coming back from Canada, she has been practicing in Salem, and she was initially associated with SPMM Hospital. And after that, now she has taken over as the consultant nephrologist and deputy medical administrator in Kauvery Hospital. And the most significant thing, like last 1 year, I could hardly get her across because she was very busy involved in COVID care, and she has treated over 2,500 COVID patients, and theirs was the first private hospital in Salem to have a COVID ward, to have COVID ICU, and also a COVID dialysis unit. I think that was something which I found quite interesting. And she has been also the nodal officer for their hospital. She has organized multiple CMEs, workshops, conferences, training program for staff, and also junior doctors, both in nephrology as well as in quality of care aspects in the hospitals. She has got multiple publications, and more than that, she is one of the popular speakers for CMEs and also in the nephrology forums in India as well as in other places. And she has received multiple awards. She got the gold medal in anatomy. I remember she was the only person in our class probably who read Gray's Anatomy all the time. And she got the best resident award from the AIMS during her DM posting. And she has got the best clinician award from the University of Toronto. And she has recently received the COVID Warrior Award awarded by the IMA Salem. And she has been faculty across many of these things, and her main area of interest in nephrology is electrolyte imbalance. From the time Dr. Mani taught us how electrolytes are controlled by the kidney, that one, epidemiology, critical care nephrology, and also in preventive nephrology. So those are her main areas of interest. And in today's talk, she will be talking to us as how evidence need to be looked in context and how evidence keeps changing over a period of time. And what is that we need to use evidence for? How do we translate that into individual patient care? I think that is the mandate for today. And I won't keep you further away from the talk. Over to Dr. Abirami. And before that, we'd request all participants to keep themselves on mute. And any questions, please put it in the chat box. We'll take it up. And this program is being recorded live in YouTube for future academic use. So over to you, Abhi.
Hi, thank you. Thank you, Dr. Maha, for that excellent introduction. I and Maha are, we go back a long way, partners in crime. With one another friend of us, we were called the terrible trio of our batch. In a good way, I assume. Dr. Kotu, thank you so much for the excellent introduction to evidence-based medicine. As you said, you had doyens speaking on it. So I'm not going to compete with them, but this is my personal discovery of evidence-based medicine and my journey through it. Give me a minute to share.
Done, Abhi. Done.
So good afternoon, everyone. This vague title is thanks to Mahalakshmi. The first disclaimer is I was never trained in evidence-based medicine. It was not there when I went to medical school. And even now, I don't think it is being taught in India that much. So my first exposure to evidence-based medicine, though we had it partially during our MD and DM days, the formal introduction was when I was doing my fellowship. All that I got was 2 days workshop on evidence-based medicine. So that is the basis of my knowledge on this. But since then, I would like to believe I've been practicing evidence-based medicine. So this whole talk is my journey with evidence-based medicine, though I didn't formally learn that or get trained in that. So it may not be as mystical as Alice's journey, but definitely it was very adventurous for me. So in today's talk, I've divided it into 3 parts. The first one I wanted to highlight, evidence is above and beyond logic. Even if the logic tells us A is causing B, take off the A, B will become all right. No, we need evidence for that. And I'll give you a nice example to explain that. The second part I'm going to talk about how to take evidence into context. In the sense, evidence continuously evolves. It's not a set of rules you memorize when you're studying in that particular field and then start applying it in your practice. So how we evolve with evidence is the second part of my talk. And final part is the most difficult part, I think, how to apply the evidence to a given individual patient. So I will talk about one of my patients and show you the journey of evidence, applying evidence. So the first is evidence is above and beyond logic. Logic paves way for evidence. Logic gives rise to a research question. But that research question needs to be answered by evidence before it can be adapted to clinical practice. This is one glaring example in nephrology. All my examples are in nephrology. Some of them might not be what you see regularly, but the idea will be conveyed and I can talk better on nephrology topics than anything else. So this is the story of erythropoietin. Erythropoietin is as old as I am in medical field. So it was actually first approved in 1989. So we've known about an hormone which would cause Rbcs production. We know, like as early as 1957, we knew like nephrectomized animals would go into anemia. There won't be any RBC production. In 1965, we learned that the erythropoietin is produced in the capillary cells. In 1977, erythropoietin was purified. 1985, the gene was cloned, and that started the erythropoietin era. So once the gene was cloned, two different groups, one from China and one from US, they were able to inject the gene into the Chinese hamster cell and produce erythropoietin in large quantities, which could then be used commercially. This is recombinant human erythropoietin. It is exactly like our normal human erythropoietin, but it is being produced in Chinese hamster cells. So it makes sense when the RBCs are low, the oxygen carrying capacity is low, the renal cortex, the deep part of the cortex and medulla, they are, as it is hypoxic, so even small changes in oxygen transport will be perceived as hypoxia by the kidney. There are multiple factors in between. The kidney produces erythropoietin, and the erythropoietin will act on the bone marrow and produce more RBCs. The increase in RBCs increases the oxygen, and then there is a negative feedback and inhibits erythropoietin. So it's a very simple and well-known paradigm on how erythropoietin works. So then it is very clear in patients with renal disease, whenever there is a reduction in renal mass, either by surgery or because the loss of function, there will be low erythropoietin and patients will be anemic. That's something we have known for a very long time, that renal patients are anemic. So it makes perfect sense to use the recombinant human erythropoietin to increase the hemoglobin and give good quality of life. And this recombinant human erythropoietin went through phase 1, phase 2, phase 3 trials. This phase 3 trial came out in 1989 and FDA approved the drug. So I entered medical college in 89. That's why I said erythropoietin is as old as my medical experience. So in the phase 3 trial, it was very clearly shown hemoglobin went up from 20, the hematocrit went up from 22% to 35%, which is somewhere from like 8% to 10% in most of the patients. There were not major side effects. Some increase in blood pressure was seen, and FDA approved this treatment in patients with hematocrit less than 30%, and the target was up to 33%. This is very important. In US, you cannot get reimbursement for a drug unless it's approved by the FDA. So the FDA would approve only up to the target of 33%, which roughly is like 11 grams hemoglobin. Once the hemoglobin crosses 11, we are not supposed to use erythropoietin. That's something which didn't sit very well with the nephrology community. For the simple reason, we have always known anemia is associated with mortality in dialysis patients. For every 1 gram drop in hemoglobin, there is a 28% increase in cardiac failure, 20% increase in recurrent cardiac failure, and 14% increased risk of mortality with just 1 gram drop. So we always felt mortality in the dialysis group, which is predominantly driven by cardiovascular mortality, can be corrected by the correction of anemia. And the target of 33% given by FDA is not very fair. So, trials trying to address it.
I muted all. Whoever is speaking, can you please mute yourself? Okay.
So these guidelines in 2001, though the FDA had approved only up to 33%, which they extended up to 36% in 96. So the initial guideline which came out in 2001 said you should try to achieve hemoglobins to 12 grams or 36%. The next guideline which came out in 2006 said, okay, it should not be lower than 11. You should try to reach up to 13. And in this particular guidelines, it was taken as a quality indicator. If 80% of your dialysis patients achieved hemoglobin of 13, then your dialysis unit was considered a good quality dialysis unit. Based on what evidence? So from 1989, this is the way it progressed. The average hemoglobin used to be 8. It went up to 9 to 10, went up to 11, went up to 13 in 2006. That was the average hemoglobin for dialysis patients in US. And the dose of erythropoietin also continuously increased from 5,500 to 7,500 per dose. Whereas in 1996, FDA had increased the target only to 36%, which is just 12 grams, and there's no further change from FDA. So what drove this increase in hemoglobin targets? Just the belief that we will reduce cardiovascular mortality and patients will survive longer. And what is this study did? This was the first one which rang the alarm bell, and it came as early as 1998 in dialysis patients who had increased risk for cardiovascular disease, that is, who had pre-existing cardiovascular disease. They tried to achieve normal hematocrit of 42%, which is about 12 grams, and compared it with 30%, which is like 10 grams hemoglobin, and they very clearly showed death was more in patients with normal hematocrit. This came as early as 1998, and if you go back, 2001 guidelines did not talk about it, 2006 guidelines did not talk about it, and the actual practice, erythropoietin was continuously used and hemoglobin target was going on increasing. So people then said, okay, in the study, they said it is because patients have already developed cardiovascular disease. It's too late. This is not helped. We need to catch them early. This is one particular trial from Canada in 2005, where they took dialysis patients without symptomatic heart disease. And again, they compared hemoglobins achieved 13 versus 10%. There was no difference in LV volume index. The study was not followed long enough, but they showed increased stroke even during that period. And the final nail on the coffin was these two trials, which came out in 2006, just before that new guidelines, which came out in 2006. This was in patients who were not on dialysis, pre-dialysis CKD. Again, the logic was the same. We are catching them late. It cannot be. Hemoglobin correction has to be good. How can it be bad? We don't want to accept evidence. So we now wanted to catch them early. We went to pre-dialysis phase and looked at the data in CKD patients who were not on dialysis. And in this first trial, there was no difference in cardiovascular mortality, but more number of patients who had higher hemoglobin when reached end-stage renal disease earlier. And once they go into dialysis, their risk for cardiovascular mortality almost doubles. And in this particular trial, both of them came within a month or so. Again, high hemoglobin group had higher cardiovascular mortality. The composite of like cardiac failure, MI, death, stroke, and end-stage renal disease. Finally, we thought there are newer erythropoietins now. We now have pegylated erythropoietin. We now have Rbcs. The logic was when we are giving erythropoietin, it has a short life. So it needs to be given repeatedly. Even then you have this yo-yo phenomenon. When you're giving it, the erythropoietin levels are very high, and then it really crashes, then it goes. So the hemoglobin also varies. So the cardiovascular mortality was attributed to that yo-yo variability. So they felt the newer drugs with long life will be better. This last trial here with 4,000 patients is one of the largest trials in nephrology. Unlike our cardiology colleagues, we are very happy when we do trials with 100 patients. So in this 4,000 patients, we looked at Rbcs, which is very long acting. Again, the achieved hemoglobin was just 12.5%, 12.5 grams versus 10.6 comparison. There was increased venous thromboembolism and stroke. Finally, our current guidelines, which came out in 2012, says don't start ESA therapy, that is erythropoietin stimulating agents, unless the hemoglobin is less than 10 and falling. So usually less than 9. And the target is don't increase it more than 11.5. So we would not start erythropoietin if the hemoglobin is over 10. And if they are on erythropoietin, we would try our best not to get it over 11.5. So what went wrong? Why this confusion? Our logic did not accept the evidence. We knew anemia causes cardiovascular mortality, But what we fail to realize is there could be multiple other paradigms. Anemia, there might be some factors which is causing anemia, which is also driving the cardiovascular mortality. We did not want to think about it. So now we understand that it's a much more complex mechanism. We know now CKD and dialysis is an inflammatory state. So inflammation itself will drive cardiovascular mortality. That will also drive the anemia. Erythropoietin, when we are using it pharmacologically, it is not the same as when it is produced in the body and it is physiological. As I said before, when we are giving it pharmacologically, especially when we give it intravenously, the value rises supranormally and then it crashes to zero. So this erythropoietin, so how it became when the values were high, we were not sure. Now we know erythropoietin has pleiotropic effects. It has some effects on the platelets. It can directly act on the endothelium. These also can drive the cardiovascular mortality. Erythropoietin not only corrects anemia, it does multiple other things. So it's an interplay of this complex mechanism which was giving those results. So whenever we see a result which is not explainable, which is beyond our logic, it should give rise to more research questions rather than saying, okay, I won't accept this evidence. This does not fit into my understanding of the problem. As long as the research mentioned is well done and it's a good quality research. That's the caveat to it. So that's the first part of the talk. Coming to the second part of the talk, evolution of the evidence. So why we need to stay updated? My understanding of being updated when I was an MBBS student was to take out the new journal when it comes out every week and read whatever is in that and just store it in mind to see if it will be useful for me later. I definitely did not remember anything in the next week itself. But that's the way we were taught, and that is how we were updating. That's something I don't do anymore. I don't even remember most of the things, and my residents probably knew or remember more nephrology than I do. I always look up. My standard answer to anything now is I will look up. My idea of updating is looking up for evidence every day. So I will explain this with an example of membranous nephropathy. All the examples I'm giving are diseases which changed during my practice. When I learned nephrology, it was different, and I'm practicing it different now. So it is very obvious and glaring to me, and it's in such a short span, things are changing so much. So idiopathic membranous nephropathy is no longer idiopathic. We now understand it better. It was described as early as 1955. We knew the histology in 1957. We know that there are immune complex deposited in the glomerular basement membrane, and then the kidney reacts to it. It forms newer basement membrane. So the basement membrane covers this and immune complex. So the basement membrane becomes thick. In the light microscopy, this immune complexes are not seen. So we just see empty spaces there, and it gives a spike-like appearance. So this spike-like appearance in membranous nephropathy is something all of us would have known during our medicine. Used to be a very standard MCQ question. This was described as early as 1957, and of course the EM pictures are newer pictures. So this is not an unusual disease in nephrology. In Caucasian population, it is the commonest cause of nephrotic syndrome in adults. Even in India, this is the second common glomerular disease in adults. It has a very variable course. 1/3 of the people have spontaneous remission. 1/3 of them have a smoldering disease, which is some proteinuria and some renal dysfunction. 1/3 of them progress to end-stage renal disease. It is categorized into primary and secondary. Secondary is when it is secondary to the other set of infections like hepatitis B, C, and some drugs. This is just a basic intro so that you can understand what I'm trying to tell. So this, what caused membranous nephropathy? As I said, we call it idiopathic, but even in 1959, we knew it was an autoimmune disease. The animal model called amen nephritis was established in 1959. When you inject rats with its own renal extract along with an adjuvant, you get a membranous-like lesion in the kidney biopsy. Later, they identified the autoantigen was megalin, which was present in the food process. So when it gets exposed to the glomerular basement membrane, then the rat reacts to it, and you get a disease called membranous nephropathy. It is immune complex mediated, clearly immune mediated. But the problem was megalin is not present in human kidneys. So for a very long time, we didn't know what was the antigen in the kidneys. But we did know it was an immune phenomenon. So during my training days and early nephrology days, this is how we used to treat. So because we knew it was immune phenomena, steroid was a obvious choice. So in the initial trials, just case control studies, steroid was found to be useful. But later on, two randomized control trial, one by Dr. Krishnan from Canada. He was one of my teachers in University of Toronto. You will hear his name again and again in this membranous. He is very passionate about it. And another from the UK group, they very clearly showed steroids does not work. So we know it's an immune phenomenon, but we know steroids per se do not work. So the Ponticelli's group from Italy came out with these beautifully designed studies. The first one was in 1985. They have a complex regimen which is called Ponticelli regimen, where you give steroids in the first, third, and fifth month, and you give an alkylating agent on the second, fourth, and sixth month. They initially used chlorambucil, and they showed 72% patients go into remission, but the remission is delayed. It does not happen during that 6 months. It takes another 6 months, and then the remission is sustained for a longer period of time. So 1995, they came out with their follow-up data of the initial study. And in 1998, they changed the alkylating agent from chlorambucil to cyclophosphamide. But because as nephrologists, we use a lot of cyclophosphamide for lupus, vasculitis, and other things, we are very comfortable using that. So they changed it to cyclophosphamide, and the results were reproduced. So for a very long time, we all used to use Ponticelli regimen. People who went to medical school during my times would have heard about it. Then in 1995, Dr. Krishnan, the same Dr. Krishnan, showed that cyclosporin was very effective. By then, cyclosporin was introduced in transplant medicine. We had good experience in using cyclosporin long-term in renal transplant recipients. We knew it modified the basement membrane and it reduced proteinuria. We had also gained experience of using cyclosporin in minimal change disease. So we went ahead and did a trial on cyclosporin because it was very, the Ponticelli regimen, the main problem was the adverse effects associated with the alkylating agents, especially gonadal toxicity, infertility, and infections. So he went ahead and did a study with cyclosporin, and he did show there's a reduction in proteinuria. He did not have follow-up data on end-stage renal disease or renal death. There was another trial from the Chinese group, and they again showed tacrolimus was useful, but it was more useful when combined with steroids, and it was equivalent to the Ponticelli regimen. But the problem was, once you stop cyclosporin, it used to relapse very quickly, unlike with the Ponticelli regimen. So what was the treatment protocol? This was in 2005. We used to use, whenever patients had membranous, we used to classify them as mild, moderate, severe. Moderate and severe would be treated, and we would treat with Ponticelli regimen. And if you were in the Western world, maybe cyclosporin. So this is what we understood, and this is what we were doing. So as late as 2005, this was accepted practice. Then what changed? We now got new insights. In 2002, Debbie et al. Described a child born to a mother who did not have neutral endopeptidase. So the child had antibody to neutral endopeptidase, the fetus. So the newborn had severe membranous nephropathy. So neutral endopeptidase was thought to be one of the target antigen for membranous. Later in 2009, we identified M-type phospholipase A2 receptor 1, which we normally call PLA2R now. This is the target antigen for membranous in more than 70% of the primary cases. So now we can stain for this in the renal biopsies. We can measure antibody to PLA2R in the blood. We now know the antibody titers correlates with disease progression. It correlates with disease remission. And many times now we don't even do biopsies when we have a typical clinical picture, and we can look at the PLA2R antibody levels. The patients who did not have PLA2R antibodies had one of these antibodies. So now we knew, yes, it is an autoimmune phenomenon. We know the target antigen. We know what are the antibodies. Then came rituximab. Rituximab is just an anti-CD20 monoclonal antibody. It depletes CD20 positive cells, meaning the B cells, which usually produces the antibody. B cells are the ones which produce antibody in the body. So though rituximab totally washes off the B cells and produces profound immunosuppression, it was not associated with other side effects like steroids, cyclophosphamide, and cyclosporin, like weight gain, uncontrolled diabetes, uncontrolled hypertension, renal toxicity, gonadal toxicity, uh, changes in the body structure. Those things did not happen. So rituximab then was explored for membranous. In the first trial, rituximab was compared with placebo, and they showed in the initial 6 months there was no change, but when you follow them up for 12 months, there is a significant difference in the remission. So almost double, 64.9% versus 34.2%. So then rituximab was compared with cyclosporin. This is again, Dr. Katran was part of this study. This is because in the Western world, cyclosporin was more commonly used than the Ponticelli regimen. Again, it was very clearly showed rituximab is better than cyclosporin. So now this is very new guidelines. It is yet to come out. This is the 2021 glomerulonephritis. Just a draft was circulated for us to give our comments, and the final version will come out. This guideline is going to come out something like this. In patients with moderate risk and high risk, rituximab would be the first drug of choice, followed by the other drugs. So here the evidence evolved with the basics, understanding of the basic science. So this is what I mean. There's no point in me memorizing so many trials of Ponticelli and the regimen and the percentage of resolution, because today when I have a biopsy of membranous, I should be ideally going back and looking up what is the current evidence saying, what is the new literature which has come on that. So evidence evolves over time, and when we say continuing medical education, I believe it is updating yourself on the patients you see and looking up evidence for your patients. This brings me to the final part of my talk, how to adapt evidence to patients. And the most important thing I want to tell you is guidelines is not evidence. So like during residency, we used to cram all these guidelines, and beyond a point, it became very difficult. Look at the hypertension guidelines. There are so many societies, each one of them come up with a guideline, and there are so many targets, so many numbers. I don't know why we should be so confused with all these numbers, and why should we memorize all these? Guidelines is not evidence. It is only to guide us how to do it. So I will explain this with one of my patients. He's a 27-year-old young adult. I saw him recently. This was this year in March. He presented to me with hypertension just diagnosed 3 days ago. Because his hypertension was 180 by 120, the primary physician thought he should look at secondary causes. He looked at renal parameters, it was elevated, and he was referred to me. He does give history of edema for 5 months, but he ignored it. He is very clear he didn't have it in the past. He had a road traffic accident 1 year ago. He was hospitalized for 2 days, and he's very sure he didn't have hypertension or elevated renal parameters. And I believe no hospitalization these days is possible without getting basic parameters like urea, creatinine, hemoglobin, sugars, and things like that. But urine examination was not done at that time. When he presented to me, his creatinine was 6 milligrams, which should always be interpreted as an GFR rather than a creatinine. The eGFR comes to 12 to 14 ml per minute, which is very low. It will be stage 5, close to dialysis. And his urine showed 3+ protein, active sediments with microscopic hematuria, but there was no RBC cast. He had significant urine protein, in the sense urine protein creatinine ratio was 3.4, which roughly translates to 3.4 grams protein excretion per day. But his ultrasound showed mildly borderline kidneys. For his age, I would have expected his kidneys to be about 10 centimeter and the cortex to be about 10 millimeter, just slightly reduced. But in a young age, with this kind of picture, no nephrologist worth his salt would not biopsy. So straight away biopsied him on the next day once his BP was controlled, and the biopsy turned out to be IgA nephropathy. I'm sorry for throwing all these nephro terms on you. I'll just give you a basic intro on what is IgA nephropathy. It is not that uncommon in nephrology circles again. This is the third common glomerular disease in India. It is very common in the Asian population. It is diagnosed by the presence of immunoglobulin A in the renal biopsy by immunofluorescence. What causes IgA nephropathy? There is abnormal IgA deposited in the kidneys. Patients can have, or anyone, even people, normal people can have high levels of IgA in the blood, but they do not get deposited in the kidneys. Normally, when that IgA is abnormal, it is either polymeric or it is less galactosylated or it has less CLLization. Some modification is there in that IgA and it makes it more anionic. And because the glomerular basement membrane is cationic, this IgA is getting deposited. So there's nothing special about the glomerular basement membrane. It can normally filter IgA. That is not an issue. But here, because the IgA is becoming more anionic, it is getting deposited. And then obviously anything which is not to be present there will elicit a reaction. A stranger comes into my house, I'm definitely going to throw him out. So the kidney reacts and there is an immune response, and then the kidney is damaged as a bystander. This has varying presentation in the light microscope. You can see mesangial proliferation, you can just see mesangial matrix expansion, you can see just a secondary segmental sclerosis, or you can see a very proliferative glomerulonephritis with endocapillary proliferation and crescents. This would be explained by what I said earlier. So it is the immune response which decides the renal injury, not the IgA per se. That abnormal IgA per se is not injuring the kidneys. Initially, we thought it was a benign disorder, but we now know more than 50% progress to ESRD. So it is kind of complex disease in nephrology. It has so much of varying presentations. There is no one fit model for this. So how do we treat it? This is the guidelines, current guidelines. But you should realize it is 2012. So what it says is anyone who has proteinuria more than 1 gram with GFR more than 50 ml per minute persisting for more than 6 months are the ones who should get corticosteroid therapy. So my patient will not qualify. His GFR is low and I'm seeing him only, he knows he has renal disease only 4 days now. He knew for 3 days and today is the 4th day. So he will not qualify in this criteria. Then what about the other type of treatment? In nephrology, we always try immunosuppressive. Whenever we see immune mechanism, we go to immunosuppression. So in our minds, immune mechanism is equivalent to immunosuppression. Okay, then what is the recommendation? We would use steroids combined with cyclophosphamide or azathioprine if the patient has crescents in their biopsy or endocapillary proliferation or rapidly deteriorating renal function. Again, it will not be used if the GFR is less than 30 ml per minute, unless there is crescents in the kidney. So again, my patient will not qualify. He does not have crescents. His biopsy is just showing mesangial proliferation, mesangial expansion, but no major chronicity. 7 out of the 17 glomeruli is sclerosed. Only less than 10% of the tubular interstitium is atrophied. That will give an indication of the chronicity of the problem, and it is very low. Because he had hypertension, you also wonder whether he's having a hypertensive renal damage. The hypertension mediated changes in the biopsy also was very mild. So he does not have crescents in his biopsy. His GFR is low. He does not warrant therapy. I should be telling him, bye-bye, your kidneys are gone. Please get ready for renal replacement therapy. But I was not very satisfied. Here is a guy who was absolutely all right 1 year ago. He's presenting with a very short history. He's only 27. Pushing him into dialysis at this stage of his life is not good. But then, anyway, the evidence is 2012. So what I should be doing is to look up what is new in that. What has happened after 2012? We have had 2 major trials. Okay, I'm sorry. Before that, One another caveat in that guideline is you should look for progression of the renal disease. So anyone who you think is a candidate for or a high risk for progression should be treated. That is another part of the evidence, the guideline. So how do we assess for progression? We look at clinical criteria. The GFR should be reduced. Patient should have a rapidly declining GFR. They should have hypertension. They should have proteinuria. He has all these four. His GFR was supposedly normal 1 year ago. And then we look at the histological parameters. We have something called an Oxford classification where we give a MEST score. The score, if it is 0, it is low progression. If the scores as it goes to 1, the progression risk is high. He's got 1 year, so he is at risk for progression. That I know even from his creatinine values. So I have to treat this guy. So what is new after that? This is one big trial which came out in 2015, Stop IgA Nephropathy, where they compared immunosuppression therapy to placebo. In this, about 55 patients received only steroids. Some of them received steroids and cyclophosphamide. And what did they find? Proteinuria reduced in immunosuppressive arm, but there was no change in GFR. The GFR in treated people and non-treated people was the same. So they concluded immunosuppression does not work. How do I take this? But in this particular trial, they did not look at histological classification. Let's assume someone has had IgA for 10 years. He will have some chronic changes, and that itself will cause proteinuria. And so he is having proteinuria. So I know he is having proteinuria and his GFR is low. And why should I bombard him with immunosuppression? He is not a candidate who would respond. So the trial did not take these features into account. The trial was done on stable patients who were followed up for 6 months to see if they are progressing or not. And then they were taken up for trial. I don't have the luxury of 6 months for my patient. And this is the next trial which came up in 2017. So here again, they looked at steroids versus supportive therapy. Here they had patients like mine with lower GFRs they had included. They had patients who had more proteinuria and they gave steroids for 3 to 6 months. But this trial was stopped prematurely because of increased adverse effects, and they had enrolled patients only from China, predominantly from China. So whether it is applicable to my patient, I don't know. Otherwise, the patient population in that study, most of them had creatinine of about 1.6 at the start of the trial. They had included histological parameters, but most of the patients had very high chronicity. As I said, tubulointerstitial scores, higher scores indicate chronicity. More than 60% of them were chronic. Again, the study does not apply to my patient. So when I went and dug more, I found this one particular trial where they had treated 38 patients. As I said, in nephrology, this is a good number. Getting a cohesive group of patients with this kind of numbers is difficult. 38 patients who had progressive IgA. So they took patients whose creatinine had increased by more than 15% in the last year. So here, my patient would fit in. They took up their histological parameters, categorized as acute or chronic, and then they used a treatment protocol of prednisolone with cyclophosphamide. Cyclophosphamide was switched to azathioprine at the end of 3 months and followed it up for 2 years, and they showed very good results. The cumulative renal survival. The cumulative renal survival was better in the treatment arm, whereas in the control arm, most of them had lost their kidneys by month 60. So I thought this study is the one which fits into my this study fits my patient the most. So what did I do? I started him on steroids, but instead of cyclophosphamide, I added azathioprine because he's a young male. Gonadal toxicity is very high with cyclophosphamide. So this is my follow-up data. 11th March when he presented to me. Now the last follow-up is was on 5th July, and his creatinine has dropped to 4.5 milligrams %. and as of now, he is doing well. So, I'm sorry. So when we look at evidence, we need to see what is the evidence, in the sense what group of patients were studied in that particular evidence and whether it is applicable to our patient. The more basic question is, when you have a problem, you should know to ask the right question. So for my patient, the right question was rapidly progressing renal failure without crescents in IgA, what should I be doing? So when I answer that question from evidence, I would be able to use that evidence for my patients. So to conclude, evidence-based medicine improves and standardizes practice. So there is no doubt about it, at least not in my mind. So we should be adopting evidence-based medicine in whichever way we can. But we should realize evidence-based medicine is not some set of rules or some guidelines which are to be memorized and then applied. It is just understanding that we have to find evidence for our patients and apply it correctly in the way it will be suitable for our patient. So we should understand evidence will evolve over time. And I personally think we always say clinical medicine is an art, not a science, but evidence-based medicine is the new art in clinical medicine. So the bottom line is we need to ask the right question of our patient, for our patient, find the evidence, and then apply it in accordance with patient's values and our local milieu. Thank you.
Yeah. Right. Thank you, Abhi, for that nice lecture. And the thing what struck me is what you were talking about. How do we look up for evidence and how do we search the most appropriate evidence for our particular patient? So if you really look up what has changed in medicine over the last few decades when we have entered is that medicine is being taught more as competency based education, right? And one of the most difficult things to teach to residents is practice based learning and improvement. I think this lecture was actually a walkthrough on how you can actually improve your knowledge. We initially thought that medical knowledge, what you gain during residency or subsequent training, is the absolute one. Whereas we need to understand that it is actually your practice needs that we need to look up more and more, and it needs to be looked at. I think that was a walkthrough for practice-based learning and improvement. And the concluding slide, you need to ask the appropriate questions for your patient in your milieu, how you can actually change the practice for your systems. I think that was the talk. I have one or two questions when I actually was listening to this. And before we take the participants' question, we'll take this. One is ignoring evidence is bad, right? It leads to avoidable harm and this thing. But more worse than that is failing to admit that we don't understand or we don't get better evidence. So that is, I think, is the most catchy point. Sometimes it becomes very difficult to see that, and it is especially true when the trials do not show significant, because this publication bias is also there towards positive publications. And what if we don't have enough evidence, or what if we don't have anything to guide us into practice? How do we go about it? That is what is, I think, would be our first question for discussion.
I think that is where clinical experience and case reports come into play. So, as I said, it is all very complex. Each patient is different. And I showed this large trials were not addressing my patient's needs. So I'm not going to go and find patients like mine and conduct a trial. It is very, very difficult. So this is where registries come into play. So whatever we see, if we document, we keep a very clear document of what we are doing, what we are seeing, and we audit our own data. So that will give some answers in the local milieu. And the second thing is the case reports. So that is where the case reports come in. So it is not all randomized controlled trials. So when we see something unusual like this, there are others who have seen like that and they have reported it. That will give us some clue. It will at least tell us what not to do, even if not telling us what to do. And beyond that, I think it is how you adapt your existing knowledge. And then it is a gray area and it is anybody's guess. And that is where I believe teachers and clinical experience comes to play a role. Till then, any newcomer would be able to use the evidence and do it. So when you have a sudden googly like this, that is when your skills are really challenged.
So you go for what is the so-called best available evidence.
Yes.
Is that what it means? The other thing which one more when we keep listening to talks about evidence-based medicine and how we translate it into practice, one more thing which comes across is sometimes we find, like as you yourself showed, that inappropriate guidelines which are not suitable to the current needs, and more important is the so-called clinical dogmas. No, this is the practice in our unit. This is the practice in our setup. So that I think is the most difficult part of dealing with implementation of evidence-based practice. I don't know whether it is a question, but it is
all the
only
dogmas started with some evidence. If you go back and ask your teacher, he would tell you why he was practicing that. And there must have been some evidence at that point of time. At least once I started my nephrology training and all, I realized everyone reads and everyone is updated and they are going through all this. It is just the way we read has changed. As I said earlier, we used to just read all the journals which came out. At least the top 4 journals was the recommendation. We had to read the top 4 nephrology journals every week as soon as it came off the press. And we need to know what was there in that. So everyone was reading and they were applying evidence to some extent. And I'm sure those dogmas had some evidence behind it. But if we would only let our residents to question those dogmas or come up with some alternate solutions, definitely it will help. The whole unit would be benefited. And it does work like that in most of the teaching institutes nowadays. At least I would like to believe so.
okay. Right. Dr. Kotu, do you have any question for Dr. Abirami before I take up the others? You're here, sir? Sir, you're muted, sir. You need to unmute yourself. Oh, fine. 1 minute. Yeah, now you will be able to do so.
Every time you do that, and I struggle.
No. What has happened was in between there was a disturbance, so I disabled it.
Yeah, it was a very good first-hand narration or experience-based narration of the evidence-based practice right from Dr. Abirami's resident days, and so many salient points she brought in. And in any particular circumstances, we know that best evidence may be nothing but the person's expertise and many times intuitions. Even when I was telling, initially when the EBM came into existence, all the senior persons got threatened because they were threatened that what is this new? Now we don't believe in all that. I've been treating for the past 30, 40, 50 years. That was the response that came. But now the things have changed. So as rightly said, and many circumstances, the best evidence could be only a case series, or it might be only the person's intuition or single case. Now, I belong to anesthesia, okay, and suppose in any of my procedures, I try to find out best evidence, like just I used to give an example. We are giving the intracardiac adrenaline or giving IV or giving the oral or the intratracheal, that kind of a studies will never ever be available. All the best evidences for the life-saving procedures are based either on the personal expertise or animal studies or those kind of things. Those things all have to be kept in mind. One thing I wanted to discuss was what Professor Dr. Abirami said in the beginning. It's not being taught in medical colleges. It's not so, madam. Now, of course, our regulating council of the Erstwhile Medical Council of India has introduced this EBM. Even the advocate being taught to the undergraduates as well, because apart from, we call many times we say the off-label or off-desk uses of EBM, apart from facilitating the best optimal care or optimal patient care, this will stimulate the thinking process, critical thinking. Many competencies can be gained by this practice of EBM, if it is introduced to the students early in their career. Some of the comments I can say. It was really a wonderful thing. With the examples you gave, narrated that.
Yeah.
Thank you, Dr. Mal.
Thank you,
Any
sir.
technical questions?
Yeah, I don't think there are any questions from the participants. But one more thing I can see is I see a lot of postgraduate students and young faculty in the group. Is there anything you want to tell them that how to understand evidence and how to put it into practice? You want to share any thoughts on that, Abhi?
Hey, as I said, I'm not formally trained in evidence-based medicine. I'm sure there is a science behind it and there is a way to do it, but I will tell you what I do. So whenever I see, of course, I take my textbook knowledge as my baseline. So when I see a patient, then I always look for what is new on that. Whenever I see a disease, I'm seeing a new patient today, I'm diagnosing a new disease, I definitely look up what is new in that disease on that day. So that's my starting point. And then the starting point would be actually therapeutics. I worry about pathophysiology and other things later on when I have time. So with a busy practice, I'm sure a lot of doctors are going to say they don't find time, but you have to find time for this. So at the minimum, I will see if there is any change in treatment for that particular disease since I last visited that disease. So there are certain things which I'm seeing every day. So it is very easy, updated, and I know what is going on. But there are some diseases which I'm seeing like once a year. So I might, like this guy with IgA with such rapid progression, I might have seen only 3 patients so far. So when I see something like that, I really start off with that. And as I said, I frame my question first. From patient point of view, what do I need to know first? So that is where I start. So I start with therapeutics. So when I find out what is to be done, and of course on the side you learn why that is being done and what is the evidence for that. So what is the reasoning behind it, the pathophysiology behind it. So you kind of learn along with it. So depending on whether you're a student or a practitioner, your question would probably be on therapeutics or the why. So that question has to be asked for every time you see a new problem. If you're seeing an old problem and you're seeing it every day, I would look it up at least once in 2 months or 3 months just to see if I've not missed out anything. Like dialysis is my bread and butter, and we are dialyzing people for so many years now. It has not changed much. I can get up in my sleep and give you dialysis orders. But once in 2, 3 months, I would go unconsciously look for what is new in dialysis, how the regimens are being changed, because those are the things you will actually miss because you're doing it every day. When you have a new problem and it's a problem which has stumped you, you might still go and find evidence. When you are doing something routinely, then you are more susceptible to fall into that rut and just keep doing it. That kind of problems I do try to look up once in 2, 3 months. What is new in that field? What is changed? What is being done? I personally believe in attending conferences, not for traveling to those cities, but to not even to listen to plenary sessions. I like going to those poster sessions and oral presentations by the younger lot. You do get to know what is happening in the field in our country. Like You get to see what they are doing, what they are presenting. So multiple things, but I would do these three. I would think these are the three things you should be doing as a practitioner to be in touch with evidence-based medicine.
Okay. Mindfulness in practice. I think that's the lesson we need to take from the theme we need to take from what you've been telling, right? Even though you've been doing it continuously, some things might creep into your practice and you need to be mindful and watch out for such things to do. And that is how I think how we can assimilate, understand evidence, assimilate into our practice. And most importantly, we need to go with that laudable goal of actually making clinical decisions based on what is the available best evidence. So that was, I think, a wonderful talk today we had on this particular topic, and it was more like stepping through. I think Dr. Kalsad wants to ask some question. You are unmuted, sir.
No, madam, no, thank you.
Okay, fine.
No, what I
Right.
want to ask
So
was, madam, no, is it
Yeah.
ethical? Do you consider the evidence based as a ethical medicine? That's all. That's my final this one. Is it an ethics based medicine? You call it as Abirami, madam?
So evidence-based medicine will become an ethical medicine if you take patient's value into consideration.
Okay, ma'am. Okay.
Yeah. I think that was one point which Dr. Gordon in his talk also emphasized multiple times, especially in the Q&A sessions, that we might have the best evidence, but evidence need to be applied to that particular patient on the context in which we look at it, and also based on what is his personal set of values and preferences. So it's not that it's just evidence says so, you need to follow that, but it still needs to be practiced with that. So that was today's talk.
Mahalakshmi, shall
Yes,
I say one thought?
Yeah, please.
I was telling the thing which challenged the practice of evidence-based was the personalized medicine, wherein each patient is different and decisions will have to be taken not on the RCTs or meta-analysis, depending upon the patient's genetic predisposition or biomarkers or phenotype, or even including psychological characters. This is on which the precision medicine or personalized medicine gives a weightage. Then some people thought whether hybridization of evidence base and this personalized medicine can happen. And this is where the patient's values come, what Dr. Prasad was asking, ethical issues. See, as rightly said by Dr. Abirami, you give enough weightage. The three components, one is the expertise, best available scientific evidence, third one is the patient values, patient expectations, etc. So wherein there will be an interplay with the personalized medicine. That's why some thinking is, you can hybridize both and you can offer the patient the best of the evidence-based medicine, best of the personalized medicine. Ultimate aim is what? All these paradigms will go for the offering the best to the patient. So ethical, so it is EBM is more of a legal, you can say it will stand in the court of law, etc. Those kind of things. But ethics is of course the way the third component there is one practice. Okay.
Right. Thank you, sir. On behalf of the Scientific
Thank you,
Forum
sir.
of, thank you, Dr. Kalsad. On behalf of the Scientific Forum of AVMC, I thank Dr. Abirami for her time and for sharing her expertise and knowledge with us. Thank you, Abhi. And
yeah, thank you. It was wonderful talking to all of you. And I should tune into more of your sessions. Very interesting topics.
Thank you. And we'll be back next week. Again, we'll be exploring this theme of evidence-based medicine and how we are going to apply it into practice. And we have another very interesting speaker lined up for next week. We will have Dr. Nishad, who's an additional professor of neonatology from JIPMER. And incidentally, he also happens to be one of the Canada-trained people. He will be talking to us about how evidence can influence the community of practice. So how you can generate evidence for your own practice group, right? Your own unit, your own department, your own institute. So how you can assimilate and develop evidence over a period of time. So that is the talk for 28th of this month. So till then, I'd request all of you to stay safe and join us for the next session. With this, we conclude. Thank you very much. Bye-bye.